if you could mute your phones on your end of the line. If you're not able to, we can mute you from, then have to unmute you if you need to ask a question.
If you want to
Have any questions, please use the chat feature.
Well, good morning, everybody. I apologize for our little bit of a rough start, but welcome. This is Sandy Pieri, and we are going to be going over the PDPM presentation for infection care and sepsis. Can't. Oh, okay. So thank you. So instructions for receiving the 1 hour continuing ed means you have to sign an attendance sheet, include your professional license number. You have to participate in the entire webinar, and you need to complete and submit the webinar evaluation. You need to complete and submit the quiz with a passing score of 80%. And you may submit questions regarding the material we cover today for the live webinar in the chat box. For the recorded webinar, you can contact the education team at 708-342-8100, or you can email lscott@provlife.com. So these are our objectives for today's session, the first half. We're going to describe the significance of multi-drug resistant organisms, commonly known as MDROs, and we're going to discuss general strategies to stop transmission of infectious organisms, including the use of contact precautions. We're also going to summarize nursing considerations and documentation for significant MDRO infections. We're going to talk about C. diff and HIV and AIDS. And we are going to summarize nursing considerations and documentation for specific body areas, including pneumonia, UTI, bone and joint infections, foot infections, wound and surgical site infections, and endocarditis. First thing we're going to talk about is prevention. And one of the things that we do for prevention is we follow antimicrobial stewardship. And the purpose for that is to use judicious antimicrobial use. And antibiotics do disrupt a normal bacteria and create an environment for resistant bacteria to grow. So we want to treat infections and not contaminants. And we're going to avoid long durations of therapy. So judicious use of broad spectrum or more potent antibiotics to treat serious infections when pathogens are unknown. Providence Life Services does use the stewardship program from Agency for Healthcare Research and Quality, AHRQ. And you should have a binder in your facility someplace with this information in it. I also recommend that you complete SBAR tools for any suspected UTI, lower respiratory infections, or skin and soft tissue infections. The next slide is a slide from CDC regarding the antibiotic resistance threat report, because MDROs do increase lengths of stays in hospitals, increase cost, and mortality for those who have them. So this is a list of important MDROs occurring in healthcare and are critical for nursing homes. Recognize and prevent, and I'm sure you do recognize most of them. So the first one is Staphylococcus aureus, which is commonly known as MRSA, and that is methicillin resistant to one antibiotic. And we do have an Enterococcus species VRE, which is vancomycin resistant. We also have a family of intestinal bacteria named Enterobacteriaceae, Bacteriaceae, and that's a big mouthful of words. And abbreviation for what they often have is ESBL, which is extended spectrum beta lactamase, and this produces resistance to penicillins and cephalosporins. And Enterobacteriaceae also can be one drug resistant, which would be carbapenem. So that is your CRE. We can also have Pseudomonas and acetonet, I can't talk today, Acinetobacter species, and those can be multi-drug resistant, which is they would be resistant to 3 or more classes when you get your lab and culture sensitivity back. That's what you would be looking at for that. Next, we have reportable diseases to the state and local health departments. And one of the things we included is fairly new problem in Illinois would be Candida auris. And carbapenem resistant Enterobacteriaceae, CRE, are both something that you would report to public health and your local health departments, and they are also expected to be added to the extensively drug-resistant organism registry. Coli food and waterborne outbreaks also need to be reported. Legionella would fall under that category. So in your handout, you do have a copy of state requirements for Illinois and Indiana, which is helpful. Next, we're going to talk about colonization, and that is the presence of microorganisms that are not causing any adverse clinical signs or symptoms in residents. But up to 50% of nursing home residents are colonized with some form of an MDRO. So MDRO colonization may increase your risk for developing infections. So residents who are actively infected or colonized with an MDRO serve as a source of transmission. So this is always a concern as well. So colonization pressure actually means higher numbers of people who are colonized increase the risk of transmission to other residents. And here we're going to look at how we're going to stop transmission. Risk for infections, this is very general. First, weakened immune systems. People who have a weakened immune system, and the examples are cancer, people who've had recent transplants, HIV and AIDS would fall into that category as well. Recent hospitalizations, recent surgeries, or prolonged antibiotic use increase the risk for infection. Shared contaminated supplies or equipment could be as simple as a towel that has contaminants on it. Indwelling medical devices and wounds. I can't stress enough how important this is to be monitoring those. They create a portal of entry for organisms into the body, and they do provide a surface for biofilm formation. And biofilm formation is a layer of bacterial colony on the surface of the device, whatever it might be, that's protected so that the bacteria will survive even if you're using an antibiotic. So you need to make sure we're keeping those medical devices and we're keeping our PICC lines clean and dressings changed and removed as soon as possible. We're going to look also at precautions. So we always start with standard precautions. We use those for all patient care, and they are based on a risk assessment, and we use common sense practices and personal protective equipment if we need PPE to protect healthcare providers from infection and the spread of infection from patient to patient. We then go to our second tier, which is transmission-based precautions. And that's when basic infection control is not enough, and we do need to increase what we use. And the patients may be infected or colonized with certain infectious agents that need to prevent infection transmission. For example, our MDROs. Contact precautions are used in the care of patients known to have suspected serious illness easily transmitted by direct or indirect contact with the resident's items. Contact precautions falls into transmission-based precaution categories. Contact precautions, we're going to be using gloves when touching patient and the patient's immediate environment or belongings. And we're going to remove those gloves promptly after use and discard them for touching any non-contaminated items or the environmental surfaces before providing care to another resident. You're also going to be washing your hands immediately after using the gloves. Gowns are used if you're going to have contact with the patient or their environment, and we usually try to use a private room, or we can cohort people together if they have the same organism. Hand hygiene is very important and must be performed before resident care, during resident care, whenever your hands are contaminated, and after resident care. We really need, as nurses, to educate the staff that work with us and family that come in to know to wash their hands. Excuse me. Use soap and water whenever your hands are visibly dirty. Exposure to a known suspected C. diff or norovirus. Before eating, after the restroom, or after, or you can use alcohol-based hand sanitizer for everything else. Your hands really does save lives. It's very important. Now we're going to go over some of the common MDROs and a little information about each one of them. And the first one we're going to talk about is MRSA. Very common in our environment and in the community, MRSA most often causes skin infections. In healthcare settings, MRSA can cause very severe blood infections, sepsis, pneumonia, and infections in surgical sites. We have VRE, vancomycin-resistant enterococci. Enterococci are found in the human intestines, the female genital tract, and the environment. This does cause infections of the urinary tract, the bloodstream, wounds, and catheters. Next, we talk about ESBL, extended spectrum beta-lactamase. So our Enterobacteriaceae family is a group of gram-negative bacteria found in the normal human intestine, including Klebsiella species and Escherichia coli. Some Enterobacteriaceae produce ESBL, which are enzymes that contribute to antibiotic resistance, including resistance to penicillins and cephalosporins. On this page, we discuss CRE, carbapenem-resistant Enterobacteriaceae. Some Enterobacteriaceae are resistant to carbapenem antibiotics, and this is the mechanism of resistance. They produce an enzyme called carbapenemase, and this enzyme, such as Klebsiella pneumoniae carbapenemase, which is KPC, renders carbapenems and related antimicrobials ineffective, which is very concerning. There are other mechanisms, most commonly the production of a beta-lactamase along with alterations of the bacterial cell membrane, so it is a non-carbapenem producing Enterobacteriaceae. And the problem with this is carbapenem antibiotics often are the last defense against gram-negative infections that are resistant to other antibiotics, so that is very life-threatening and can be. A pan-resistant CRE is someone who's pretty much resistant to everything, so that person would be very difficult to treat. And invasive infections of the bloodstream, for example, caused by CRE have been associated with very high mortality rates up to 50% in some studies. So that is also very concerning. Move on to Acinetobacter, found in soil and water. That's where it lives, can live on skin and environment for several days. More common in healthcare settings that house very ill patients, especially folks with tracheostomies, ventilators, or have open wounds. And this can cause serious pneumonia, blood, and wound infections. Next, we have Candida auris, which we did kind of mention earlier. It is a drug-resistant fungus that spreads quickly and has a high mortality rate. And more than 1 in 3 patients with invasive C. auris will die from a blood, brain, or heart infection. Specialized lab technology is required to differentiate C. auris from other fungi, so it to ensure we have the effective treatment that we need. So that is very significant for that too. Talk about it's not an MDRO, but Clostridium difficile, and it is very, very apparent in our environment. It is associated with recent antibiotic use, especially in hospital and care facilities. C. diff spores live in the digestive tract and are passed from feces to food, surfaces, and the environment when hands are not washed with soap and water. Can persist in the environment for weeks and months. That's why it's very, very important that we make sure our rooms are kept clean. Complications of C. diff are dehydration and can result in kidney failure, toxic megacolon, where the colon becomes greatly distended, bowel perforation, or even death. These are some of the things we should be documenting. So when you're assessing your patient, you should be documenting daily while they have C. diff the following concerns. Do they have abdominal discomfort? Do they have pain? Do they have cramping? Have loose or liquid stools? Frequency and pattern is important. Skin integrity is important. Do they have contact dermatitis? Is that being treated? And are we asking our nurses aides and communicating with them the information that you need to know every day about that person's condition? So please make sure that you are asking them questions so you can document accurately about what the care of the resident is. Now we're going to move on to HIV and AIDS, human immunodeficiency virus. HIV damages the immune system. It interferes with the body's ability to fight disease-causing organisms. Acquired immunodeficiency system is AIDS. It is a chronic, potentially life-threatening condition caused by HIV. When a person with HIV develops certain opportunistic infections or specific cancers, their CD4 cell count drops below 200 cells per millimeter, they are diagnosed with AIDS. Will be HIV stage 3. These opportunistic infections are caused by particular fungi, parasites, viruses, bacteria such as TB or other mycobacterium. Frequently swollen lymph nodes is often the first sign of HIV, and there are several other diagnoses that are related to HIV. For example, a cytomegalovirus, candidiasis, toxoplasmosis, and sometimes mono or shingles. Nursing considerations for your folks with HIV/AIDS. Need to be concerned about opportunistic infections they might be exposed to, pneumonia, empyema, bone or joint infections, meningitis, bacteremia, and TB. Might develop skin issues, like I said, shingles, herpes zoster. They could also have oral ulcerations a lot of times. Candidiasis, gingivitis, and thrush are common. Changes in mental status related to encephalopathy. I have in the past seen patients with HIV have encephalopathy. Pain management, I'm sure there must be some discomfort from all of these things. I would say they suffer from poor appetite. A lot of times these folks are very frail. Poor appetite, weight loss, so we really need to be looking at their nutrition status. I would think depression would be something when you're dealing with so many illnesses. It might be something to consider when you're interacting with them. Pneumonia. Pneumonia can be caused by bacteria, virus, fungi. It's fairly common in our environment for people to have pneumonia at times. The symptoms are cough, phlegm, fever, chills, difficulty breathing. Other symptoms might be confusion or chest pain, nausea and vomiting. And as nurses, we should be monitoring their lung sounds, their breathing status, their cough, if they're using oxygen, who SAT is, and what their activity tolerance is. I also recommend that you do a suspected lower respiratory infection SBAR to complete that assessment to give more evidence-based information to the provider, whether it's the doctor or nurse practitioner you're talking to. A little bit about general information about urinary tract infections. It can involve the kidneys, ears, bladder, and urethra. Common symptoms are burning or pain in the lower abdomen, lower back or flank, fever, urination, frequency and urgency of urination. They might even have acute incontinence from it. UTIs require contact precautions if it's one of those bacteria. Please document this in the nurse's notes to make sure we are making people aware of that. And we need to do a suspected UTI SBAR to complete the assessment and prevent more evidence-based information to our provider. Specific body areas, joint infections. Bacteria and viruses or fungi spread through the blood or from a nearby infection into a joint. Pain, swelling, and fever usually occur within hours. Joint fluid is withdrawn in a culture done prior to treatment. Factors are artificial joint replacement, needles that we use to inject meds, chronic illness, older age, folks with arthritis, bacteremia, or residents on dialysis. If we are on antibiotics for a long period of time, please make sure we are documenting that in our daily notes for this person. Foot infections are often caused by a group A, strep, or Staph aureus. Related to cuts, abrasions, puncture wounds, or trauma. Cellulitis is often the first sign. Erythema is a bright red skin. There could be edema and pain. Risk factors include venous stasis, lymph disease, and neuropathy. And the treatment for that is usually IV antibiotics and local wound care. So please document in the nurse's notes about your IV antibiotic use, changes, the condition of the skin wound, and if they have pain, and their response to treatment. Let's talk about wound and surgical sites. These are the things you would be looking for. So for an infected wound or surgical site, you should assess daily and document and monitor warmth, redness, pain, drainage. Is it purulent, serous, or odorous? Is it copious? Is it scant? And any delayed healing of a surgical site really does need to be reported. To document all wound assessments as well as care, including the cleaning the wound, applying the treatment and dressing as ordered, and the client's response. Any change of action that you plan to put into place. Now let's move on to endocarditis. It's also an infection of the endocardial lining of the atrium and ventricles. Risk factors include heart valve, heart defects, rheumatic heart disease. Sorry, I hear a lot of background noise. I think I need to. Okay, thank you. Sorry about that. I can hear myself talking. So, like I said, are heart valves, heart defects. The pathogen enters the bloodstream through dental, oral, respiratory, or esophageal procedures. Heart valves can be damaged, leading to a life-threatening complication such as stroke. Symptoms include fever, shortness of breath, night sweats, weight loss, muscle and joint aches, and new or changing heart murmur, edema of the abdomen or lower extremities, and diagnosis is usually done with a blood culture and an echocardiogram. I don't know why. Nursing considerations for endocarditis is to make sure we're doing good oral hygiene and the residents with underlying heart conditions should be considered for antibiotic prophylaxis if they're going to have an invasive procedure. People with endocarditis are treated with antibiotics, and between 14 to 37% of them may require to have surgery. That's not a really big number. So let's go over some other nursing considerations, some general thoughts. To prevent transmission, we're always going to use standard and transmission-based precautions with emphasis on hygiene, and we need to educate and monitor staff, residents, and family. We always need to, with residents with infection, to manage their vital signs. They tell you a lot. Infection site care, making sure they're hydrated well, they're eating well, skin care, depending on what their condition is, and respiratory management. And we need to support the whole person. If they have multiple issues going on at the same time, that's very hard on a person to deal with, and monitoring for signs of sepsis. We also need to document all assessments, interventions, responses, client and family education, any communications, especially use of transmission-based precautions. So when we document, we need to put in detail meals, therapy, life enrichment is being done in the residence room. And we need to do resident assessments for respiratory, cardiac, skin, GI, whatever areas you need to focus on. To also document the resident's functional ability and level of assist needed. And we need to have a plan of action. Are we improving or not? Does there need to be a resident response? Do we need to do education for the resident or family? And communication. Are we notifying the physician, the nurse practitioner, whoever we need to make sure we're doing the best care for our residents? And on that note, I'm going to switch over, and Linda Scott is going to join us right now. Thank you very much.
So much, everyone. This is Linda Scott, and now we're going to move on to sepsis, nursing care, and documentation. And our objectives for this session are we're going to define sepsis and septic shock, describe nursing considerations for early detection of sepsis, and describe nursing management and documentation for sepsis. So just a little background information about how challenging sepsis is. In this country, sepsis strikes over 1 million Americans every year, and there's a very high mortality rate. The number of sepsis cases per year is rising, and this is due to our aging population, the increase in drug-resistant bacteria, the increase in surgeries, medical devices, and treatments that we're using. However, sepsis is often preventable and treatable. This is the most expensive condition that's treated in our hospitals, and in 2011, the cost for that year was over $20 billion. It's also a leading cause of death in our hospitals. In 3 hospital deaths is due to sepsis. And people who have experienced sepsis have an increased of dying even several years after the episode. The definition of sepsis has been updated by the Third International Consensus Definition for Sepsis and Septic Shock, which was developed in 2016. Periodically, this is reviewed and updated. So this was Sepsis 3. And so this new definition of sepsis, or relatively new, is a real mouthful. And sepsis defined as life-threatening organ dysfunction by dysregulated host response to infection. So if we unpack that a little bit, normally when we have microorganism invasion into the body, The body mounts a response, an inflammatory response, and attacks the invader. Sepsis. This is not well controlled, so it's kind of like a wild response on the part of the body. So that's what we mean by dysregulated. Then septic shock is a subset of sepsis. So this is just really an increase when we have circulatory and cellular metabolic dysfunction, which is associated with a higher risk of mortality. And what happens here is we have a persistent hypotension that's taking place. So we have greater and greater levels of organ anoxia. Septicemia is not really a term of choice, and it's not often used in the medical literature anymore. It's often used synonymously with sepsis. And septicemia occurs when an infection elsewhere in the body, such as the lungs or skin, enters the bloodstream. It's defined here because in the PDPM case mix index, there are 4 payment groups that relate to serious medical conditions such as septicemia. So that's why we've included that definition. When we look at the most common infections that can lead to sepsis, number 1 is an infection in the lung. So someone who's got pneumonia, and then that infection just really starts to take over. And that's in the adult population, 35% of the cases of sepsis had their origin in the lung. Then next we have UTI, also very common in our settings, both pneumonia and UTI. UTI is about origin about 25% of the time, so there's a kidney infection. And then 11% each for an infection that originates in the gut. So this would be some type of a rupture, like ruptured diverticulum, some abdominal surgery, something like that. And the skin infection would be an infected wound or surgical site infection. The causes are most often bacteria, such as Staph aureus, E. coli, and various types of streptococcus, but they also can be caused by viruses, fungi, and parasites. So what will we see? The signs and symptoms of sepsis can include a combination of these: rapid heart rate, fever, the person's shivery, or they feel very cold. So we can have hyperthermia or hypothermia. Sudden change in a mental status, so the person will be confused or disoriented. So we've got like a delirium state. Person may be very sleepy or difficult to arouse, experiencing perhaps shortness of breath with rapid respirations. They may complain of extreme pain or discomfort, or if they're not able to communicate well, may give evidence of extreme pain. They may feel like they're going to die. This is a very, very ill person. Their skin to touch may be clammy or sweaty, but the appearance of it may be pale or discolored. So this is quite a list of symptoms. So what we would watch for a combination of these symptoms. What is happening regarding the pathology? What's really going on inside? Well, sepsis is a complex dynamic disease in which aspects of the inflammatory response, as we said, become dysregulated. So for any given patient, it would be an oversimplification to say that they had a hyperinflammatory response or an immunosuppressive response. It's just a response that is out of whack. So there are some changes that go on. The endothelial cell lining in the vessel wall starts to allow fluid to leak from the vessels into the tissues. So we may see a puffy appearance in this person as we are having fluid leaving the circulatory system and into the other tissues. So frequently there's coagulopathy that accompanies sepsis. And this increases in severity as multiple organ failure and septic shock may develop. So the clotting mechanism is activated, and that can start a cascade, which results in a global tissue hypoxia and organ dysfunction, and that can result in septic shock. We look at areas of the body, it's pretty much anywhere of any of our major organs can be very seriously impacted by this hypoxia. So if we start with the central nervous system, we may see an abrupt change in the mental status of this person. Particularly impacting the lungs. The person will have difficulty breathing, a more rapid respiratory rate. Their PO2 will be decreased. If it's affecting the liver, we'll see changes in the bilirubin and in the INR. The heart, if the cardiovascular system is really impacted, we may see there may be abnormal heart pumping function with tachycardia and hypotension. Involvement will be evident through a significant decrease in the urine output, and the creatinine will be going up. Also, we may have some abdominal signs. So there could be some abdominal pain representing an ileus or peritonitis or pancreatitis. And the hemostasis, platelet count will be decreasing under 100,000. So that's kind of an overview of the impact in the body. So moving on to how can we detect sepsis? The population that we are serving, it can be very difficult because the signs of both infection and of organ dysfunction can be very subtle and difficult to recognize in older adults with multiple comorbidities. It may be really kind of non-specific or even blunted or absent, such as fever. It's not uncommon for the older adult to not really be able to mount significant fever. So this may be blunted or absent. There's also a decreased incidence of tachycardia and hypoxemia. These individuals are frail. They have multiple comorbidities. They're getting other medications that factor in and make this a more complicated situation. Also, there are some non-specific symptoms that we could see, such as confusion, delirium, weakness, falls, anorexia, and incontinence. Those are all pretty non-specific and can be attributed to other things also. So sepsis is the most common admitting diagnosis for patients who are to the hospital from skilled nursing facilities. And in the emergency room, nursing home residents are 17 times more likely to be diagnosed with sepsis than non-nursing home residents. You can just really see how prevalent this is, what a big issue this is for our population. So because the signs and symptoms are more nonspecific in older patients, especially those with multiple comorbidities or cognitive impairment, really virtually any acute change in condition could represent a possible sepsis due to an infection. And virtually any of the organisms that Sandy was mentioning in the first half of this webinar can progress to sepsis in an individual. So what tools do we have to help us detect sepsis in the population? So the first tool we'll look at is the 100, 100, 100. Does the resident just not look right? So this is a tool that was developed a number of years ago by the Minnesota Hospital Association as part of their Seeing Sepsis campaign. So 100, 100, 100 for, first of all, is the temperature, the person's temperature above 100. So as we said, our population may not mount that high of a fever. Maybe their baseline temperature is 97.6. So if they are 2 degrees higher, that for them would be a fever. Also could be hypothermic. But again, just keeping in mind, kind of a hook to hold on to that 100 temperature. The second 100 relates to the heart rate. So is the heart rate above 100? And the third 100 is the systolic blood pressure below 100. And again, we have to have a little explanation of this because perhaps this person's baseline systolic is more like around 160. Well, if we see 110, 115, that is a significant decrease. So we're looking for 100 basically, or 40 or more millimeters of mercury below their usual baseline. And the appearance of this person is just ill. They just look like a really sick person. So the CNA may just come to you and say, I don't know what it is, but this person just doesn't look right. So they've just got a really different appearance. So if you work with the CNAs, help them to understand the importance of 100, 100, 100, and the person just doesn't look right. If they come to you, do make sure that you follow up right away and do a nursing assessment on this. Tools that we have to use are the Interact Care Paths, and there are about 10 of those, and a number of them really do relate to sepsis, such as the path for fever, care path for symptoms of acute mental status change, or the path for symptoms of shortness of breath. So those also could help us to detect early and acute changes in our clients. We've been using the stop and watch tool for quite some time now. The CNAs are documenting on that in the touch screens. They should be bringing this to your attention if anything just looks different about their resident. And we want to encourage family members and the IDT, the interdepartmental team as well, to be using that tool. So for example, if a housekeeper who is used to this particular resident really observes something just doesn't look right about this person, you want them coming to you and telling you so that, again, you can do a nursing assessment and follow up. Then we nurses have the SBAR tools. Help us communicate thoroughly to the practitioner that we're seeing something. And when we communicate, we want to also communicate that we are concerned about sepsis. Another tool that we can use is called the Q-SOFA, which stands for Quick Sequential Organ Failure Assessment. And this is a real mini version of the SOFA tool, which is used in the ICU setting. The Q-SOFA is recommended for use in non-ICU patients in the hospital. It has not specifically been validated in the post-acute or long-term care setting, but I do think that it is very useful to us, and the literature is indicating that we should be keeping this in mind in our setting. It's really a very simple tool. It looks at respiratory rate. So is the respiratory rate increased? It's 22 or over. An altered mental status, systolic blood pressure 100 or below. And if for each of those factors, it scores 1 point. And according to the tool, a score of 2 or more suggests organ dysfunction. So this is not a particularly specific diagnostic test for sepsis. It's more of a mortality predictor, so it tells us something serious is going on with this person. It kind of is a predictor of poor outcomes. So these patients should be more thoroughly assessed. You know, this gets our attention to that. This would be, again, in the presence of known or suspected infection. The Q-SOFA. So some other tools that we have, one is the Act Fast. This was one of your handouts. So if you want to just turn to that, and we'll take a look at it for a moment. It says at the top, Act Fast. Early detection of sepsis requires fast action. And this was part of the Seeing Sepsis campaign, again, from the Minnesota Hospital Association. And even though this tool is designed for long-term care, it was designed before the updated definitions of sepsis and septic shock, but it still is very useful. So if we look on the right-hand side, again, we see the 100, 100, 100, and the resident just doesn't look right. So that's the tool we just reviewed together. Then if we look on the left-hand column, if the resident has a suspected infection in 2 or more of these. So again, we see the elevated temperature or hypothermia, elevated pulse of 100 or more, systolic blood pressure, 100 or 40 millimeters or more of mercury from the baseline, the respiratory rate elevated with a PO2 going down, and altered mental status. So it's really kind of incorporates many of those Q-SOFA items. So if alerts us to a possible sepsis, then our plan is review the person's advance directive. Are they a person that open to going to the hospital? Are they on hospice or palliative care? Do they have a do not hospitalize order? We want to review that, contact the practitioner, and also contact the family with what's going on. If this person is going to be going out to the hospital, then this is a 911 call. This is not just a transport. This is an emergency. So transport call 911, and then when you are making your communication to the hospital and to the EMS, report that you have a positive screen for sepsis. This is going to move it along much more quickly for the person in the ER. They're not starting from square one. They're taking the benefit of the observations and assessments that you've done. So this needs to move along very quickly. If the person is going to stay in the facility, then there are labs and IVs and things that we're going to have to do, which we'll talk about in a moment. Then as we move on down through the bullet points, you can see comfort care. If this person is going to be staying in our facility for comfort care, these are the things we're going to have to be paying attention to, which are pain control, control the symptoms, the fever, repositioning, the fluids, things like that. So that is one tool that we have to use. A second tool that was also another handout of yours called Skilled Nursing Facility Care Pathway, Symptoms of Sepsis and Septic Shock. And this is a newer tool. It was developed by the QIO in New York State. And you will see really some similarities in this tool with the tool that we've just looked at. So again, we're starting at the top, looking at the symptoms or signs of sepsis, and this is in the presence of a confirmed or suspected infection. So again, we're looking at the fever or hypothermia, rapid heart rate, breathing, shortness of breath, confusion, complaints of pain, and then their appearance, that pale discolored skin. If this gets our attention that something is up, then of course we're going to take the vital signs specifically, and it does say draw WBCs. Moving on down to our next box, it says, in the presence of infection, if there are the vital sign criteria met, then we're looking for 2 or more of the following: mental status, hypotension, tachypnea, and then it also mentions decreased urine output because of the high incidence of UTIs in our setting that can really turn septic. And then you can see on the right there the updated definitions of sepsis and septic shock. Notify the practitioner, and then if we are suspecting sepsis, it is recommended that all patients with suspected or confirmed infection and possible sepsis considered for transfer to an acute care hospital. The Surviving Sepsis Guidelines, which came out in 2016, recommends that the management of sepsis is beyond the capability of most skilled nursing facilities. Therefore, the majority of patients suspected of possible sepsis transferred to an acute hospital should be considered to safely and optimally manage this condition. So again, consider this person for transfer. Now, there are some exceptions to this, and that is if the patient has a do not hospitalize order or an order for just palliative care or hospice, or if the patient themselves or their power of attorney wants the condition treated but not in the hospital. The other half of that is the facility has to be capable of managing the sepsis according to the recommended interventions. So that is where we are going to move on to our next handout, which you will see the hour 1 bundle. So you again have a handout of this. You see the patient laying in bed on IVs and monitors. So in the previous guideline for managing sepsis, we talked about 3-hour bundle, a 6-hour bundle. Now we have the 1-hour bundle. And that does not mean that all of these activities are completed in an hour, but it means that they are all initiated in the first hour that we suspect sepsis. So this starts with measuring the lactate level. Lactic acid is produced when organs are hypoxic. So although it's not diagnostic specifically for sepsis, it is a huge, significant indicator that organs are hypoxic. So the lactate level has to be drawn right away, and then obtain blood cultures from 2 different sites, not from the PICC line, administering any antibiotics. And then third, administer broad spectrum antibiotics. And frequently there are several antibiotics, broad spectrums, that will be initiated just to throw a very broad blanket on this situation. Hopefully one of the broad spectrum antibiotics will be effective against whatever is causing this huge infection. I know that seems to kind of go counter current to our antimicrobial stewardship, but this person's life is really in jeopardy. And so for that reason, there's just starting numerous broad spectrum antibiotics until those cultures come back. Then they're going to back off on the broad spectrums and really narrowly target exactly what that culture shows. Then we're going to begin rapid administration of crystalloid solutions like normal saline 0.9 or Ringer's lactate for hypotension or an elevated lactate level, and perhaps even also use vasopressors if hypotension is still problematic even after this fluid resuscitation is going on. So you can see that the actions are very intense. So in most instances, this is to be done in the hospital. So we are going to be getting some folks back from the hospital that were in for an acute period of sepsis. So following hospitalization, what are we going to do for these people? One important aspect is going to be medication reconciliation and titration. When this person was hospitalized for sepsis, very likely that some of the medications that they were on for their chronic conditions were probably discontinued, like their GI meds, their Synthroid and things like that, probably some anticoagulants. If they were on that, there were definitely changes that. So some things were discontinued or acute medications that were initiated in the hospital, such as there were some antipsychotics that were started because of the acute delirium state, which I know we're not at all in favor of antipsychotic, but this was for this specific delirium state, so it's going to have to be discontinued. And other medications might need titrated during the recovery process because these organs may have sustained really some significant injury during this period. So this titration of medications is also an issue. And again, that's going to be something that the physician's going to be working on. So following hospitalization, these people who have survived the sepsis their battle is not over, because they are going to continue to feel very weak, very fatigued. They're going to have some other symptoms, breathlessness perhaps, generalized pain, decreased abilities, their mobility, some difficulty sleeping, weight loss, loss of appetite, and confusion also can be very significant. We also have to watch these individuals for the likelihood of rehospitalization. Number one reason for rehospitalization is infection. It could be because this person's individual biome was so disrupted with the antibiotic treatment that they were receiving that now other opportunistic organisms were able to invade and take over. It could be that there was an incomplete antibiotic course, and so whatever it was, the organism that was behind the sepsis is now starting to show up again. This person may have residual lines, tubes, etc. So infection is the most common cause for rehospitalization. So watch these individuals closely. Also, they could experience an exacerbation of congestive heart failure. Again, medications inappropriately started or some lingering myocardial suppression. They experienced acute injury, acute kidney injury. So again, some of their meds are going to have to be redosed for their change in glomerular filtration rate. They may have this lingering myocardial suppression, again, can impact their kidney function. So that's another possible reason. COPD exacerbation with recurrent microaspirations, post-pneumonia, bronchiolitis, of compensatory muscles, or maybe failure to resume inhalers or things like that. And finally, possible aspiration due to delirium, some permanent cognitive impairment, or post-intubation swallowing dysfunction. So if you look at the small box at the bottom, you can see the rehospitalization rate for 30 days. So this is a big concern to us. 30-day rehospitalization rate for these individuals is 20 to 32%. So very, very high. When we look out 3 months, it goes up to 40%. And when we look out to a year, about 63% of these individuals are rehospitalized. So it seems if a person survives the sepsis that it should be the worst should be over, but actually up to 50% of these survivors are left with post-sepsis syndrome. and this is a residual physical and or psychological long-term effects. And one very significant one is decreased cognitive function. These symptoms can last from 6 to 18 months, can last for years. An individual who survived has there's a threefold increase in cognitive impairment in these individuals. Some of this may improve over time. Very often the person never does return to their baseline cognitive ability. Often they have 1 to 2 new functional limitations in their ADLs, and 1 in 5 has a post-acute mortality, which means death within 2 years following because of all of this organ damage, the residual damage that was done. And these are some really, really concerning symptoms that they can be left with that you see here: nightmares, hallucinations, panic attacks, pain. Some people had to experience amputations due to that, hypoxia, depression, dysfunction, PTSD. So really, these individuals are faced, this can be a long-term thing. And so we need to be very sensitive to these individuals, work with them, and help them to understand that what they are experiencing is normal. And there is a website for this as well on the Sepsis Alliance. Also, C has a fact sheet that's called Life After Sepsis, What Sepsis Survivors Need to Know. Because these individuals can get very discouraged that they are not bouncing back the way they had hoped and planned. So finally, there are so many assessments to be making, interventions. We have to watch for the responses, of course, of the client, do lots of client family teaching, lots of communications that we're going to be having with the family, with the practitioner. So all of these things need to be documented. So all of the things really that we've covered need documentation. I just want to thank you again. That brings us to the end of this webinar. Thank you again for your patience as we struggled with some connectivity in the beginning. If you have a question, feel free to enter it in the chat box, or if you have a question that comes to you later on, please do not hesitate to contact the education department. So thank you so much. Please do remember to complete your quizzes and submit them, your evaluations, and also your sign-ins. Thanks so much. Goodbye.